I want to have a conversation with you about something that comes up constantly in my practice. Patients who've been told their cholesterol is fine based on a standard lipid panel and then go on to have a cardiac event anyway. This isn't rare, and it isn't a fluke. It reflects a genuine limitation in how we've traditionally measured and communicated cardiovascular risk using standard cholesterol numbers alone. Let's talk about why this happens, and about a specific, increasingly available test that provides a meaningfully more accurate picture for many patients. Your standard lipid panel reports total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides. Here's what most patients don't realize, and honestly, what wasn't emphasized enough in medical training for a long time either. Your LDL cholesterol number, the one most commonly discussed and targeted with treatment, is actually a calculated estimate of the amount of cholesterol contained within your LDL particles, not a direct measurement of how many actual LDL particles you have circulating in your bloodstream. Here's why this distinction matters enormously. And I want to walk through the mechanism carefully, because this is genuinely important. It's the LDL particles themselves, not simply the cholesterol they carry, that physically enter your artery wall and initiate the plaque-forming process we've discussed elsewhere. Two people can have identical LDL cholesterol numbers on a standard panel, while having meaningfully different numbers of actual LDL particles. If one person's particles are smaller and more cholesterol depleted, while the others are larger and more cholesterol rich, the person with more smaller particles, even with an identical calculated LDL cholesterol number, generally carries higher actual cardiovascular risk because it's the particle count, not the cholesterol content within those particles. That determines how much material is available to penetrate your artery walls. This is where a test called apolipoprotein B, commonly abbreviated ApoB, becomes clinically valuable. Every LDL particle, along with several other atherogenic, meaning plaque-promoting particle types, carries exactly one ApoB protein on its surface. This means measuring ApoB directly counts the actual number of these potentially harmful particles circulating in your blood, rather than estimating based on their cholesterol content, providing what many cardiologists and lipid specialists now consider a more direct, more accurate measure of your actual atherosclerotic risk. I want to share the research supporting this, because I think it's genuinely compelling. Multiple large studies and meta-analyses comparing ApoB to standard LDL cholesterol as predictors of cardiovascular events have found that ApoB is at least as predictive, and in a meaningful number of studies, more predictive of actual heart attacks and cardiac events than LDL cholesterol alone. This has led several major cardiology and lipid organizations to recommend ApoB testing, particularly in specific patient populations where standard LDL cholesterol may be less reliable as a risk indicator. Let's talk about exactly who benefits most from getting this additional test, because I don't want to suggest everyone needs to overhaul their entire approach to cholesterol testing. Patients with elevated triglycerides, generally above 150 milligrams per deciliter, often have what's called discordance between their LDL cholesterol and their actual particle number, meaning their calculated LDL cholesterol may look reasonably normal while their actual ApoB, and by extension their actual particle count, is meaningfully elevated. This is a particularly important group to test. Patients with diabetes or metabolic syndrome frequently show this same pattern: elevated small, dense LDL particles that carry relatively less cholesterol per particle, meaning their calculated LDL cholesterol may underrepresent their true particle-based risk. Patients with a strong family history of early heart disease, or who've had a cardiac event despite seemingly reasonable standard cholesterol numbers, are another group where I'd specifically recommend this additional testing, since it can help identify risk that the standard panel alone missed. Now, I want to introduce a second related marker that deserves its own specific mention: lipoprotein a, often written as Lp(a). Here's what makes this particular marker different from everything else we've discussed. Unlike LDL cholesterol, which responds significantly to diet, exercise, and standard cholesterol medications, Lp(a) is almost entirely determined by your genetics, remains relatively stable throughout your life regardless of lifestyle changes, and is not effectively lowered by most standard cholesterol medications, including statins. Here's why this matters clinically. Elevated Lp(a), which affects roughly 1 in 5 people, is an independent risk factor for cardiovascular disease, meaning it contributes to risk beyond and separate from your LDL cholesterol or ApoB levels. Because it's genetically determined and testing is a simple one-time blood test, unlike LDL cholesterol, which requires repeated monitoring, most guidelines now recommend checking Lp(a) at least once in your lifetime for every adult. Since knowing you have an elevated level, even though it can't be directly lowered through lifestyle changes in most cases, meaningfully changes how aggressively your other modifiable risk factors, LDL, blood pressure, blood sugar, should be managed. I want to be genuinely clear about something important here. None of this means your standard cholesterol panel is useless or that you should ignore your LDL cholesterol number. Standard LDL cholesterol remains a genuinely useful, well-validated marker for most people, and it's still the primary target for most cholesterol-lowering treatment decisions in current clinical practice. What I'm describing is additional complementary information that provides a more complete risk picture, particularly for specific patient groups where standard LDL cholesterol alone may not fully capture actual risk. Now, if you're finding this valuable, this is exactly the kind of detailed, clinically nuanced conversation I like having on this channel. The kind that goes beyond a standard appointment's time constraints to actually explain why certain additional tests might matter for your specific situation. If you haven't already, go ahead and subscribe because there's more content like this coming. Let's talk about how to actually get these tests, since I know that's a practical question many of you have. ApoB and Lp(a) are both standard blood tests, available through most major laboratories and increasingly covered by insurance, particularly when your doctor documents an appropriate clinical reason, such as elevated triglycerides, family history, diabetes, or prior cardiac events despite seemingly normal standard cholesterol. If your doctor isn't already familiar with recommending these tests routinely, bringing them up specifically by name, ApoB and Lp(a), is a reasonable, informed way to start that conversation. Let's talk about coronary calcium scoring too, since this represents a genuinely different but complementary type of test worth understanding. While ApoB and Lp(a) measure risk factors, blood-based markers that predict future plaque development, a coronary calcium score is a specific type of CT scan that directly visualizes and quantifies calcified plaque that is already formed in your coronary arteries. This provides a direct, individualized measure of your actual current plaque burden, rather than a risk estimate based on blood markers alone, and can be particularly valuable for patients where there's genuine uncertainty about how aggressively to treat borderline risk factors. Let's talk about how these different pieces of information work together in a comprehensive risk assessment, since I don't want you to think of these as competing tests where only one matters. Standard cholesterol provides your foundational risk picture. ApoB refines that picture with actual particle count. Lp(a) identifies an important genetic risk factor not captured by either of the first two measures. And coronary calcium scoring, when appropriate, provides direct visual confirmation of actual plaque burden. Together, these provide a considerably more complete, individualized risk assessment than relying on standard cholesterol alone. Let's talk timeline, because I want to give you a realistic picture of how this information actually gets used clinically. Getting these additional tests done is straightforward, typically a single blood draw for ApoB and Lp(a), and the results are immediately actionable information for you and your doctor to discuss, rather than something requiring weeks to interpret. The value comes from how this information then shapes your treatment plan, potentially adjusting how aggressively your doctor recommends managing your other modifiable risk factors based on this more complete picture. Let me answer a few questions patients frequently ask me about this topic. First, if my ApoB comes back elevated even though my LDL cholesterol looked normal, what actually happens next? This typically prompts a more thorough conversation with your doctor about your overall cardiovascular risk profile, and depending on the full picture, may lead to more aggressive lifestyle recommendations, consideration of cholesterol-lowering medication even with a normal-appearing LDL number, or additional testing like a coronary calcium score to further clarify your actual risk. Second, if my Lp(a) is elevated, is there truly nothing I can do about it? While Lp(a) itself is largely genetically fixed and not significantly modified by most current lifestyle interventions or standard medications, knowing you have this risk factor is still genuinely useful information, since it typically means being more aggressive about managing your other modifiable risk factors: LDL cholesterol, blood pressure, blood sugar, weight, and there are newer medications specifically targeting Lp(a) currently in clinical development that may become available in the coming years. Third, should I ask for these tests even if I have no known risk factors and feel completely healthy? For most people with no significant risk factors and a family history free of early heart disease, standard cholesterol testing remains a reasonable primary approach, though a one-time Lp(a) check is increasingly recommended for essentially everyone regardless of other risk factors, given how straightforward that particular test is and how significantly it can change risk stratification for that specific subset of people who do turn out to have an elevated level. So here's what I want you to take away from our conversation today. Standard cholesterol numbers, particularly calculated LDL cholesterol, provide genuinely useful but incomplete information for a meaningful subset of patients. ApoB offers a more direct measure of the actual atherogenic particle count driving plaque formation, and Lp(a) identifies an important, largely genetic risk factor invisible on a standard panel entirely. Together with your standard lipid panel, and when appropriate, coronary calcium scoring, these additional tests provide a considerably more complete, personalized picture of your actual cardiovascular risk. If you have elevated triglycerides, diabetes, a strong family history of early heart disease, or you've had a cardiac event despite seemingly normal standard cholesterol, bring these specific tests, ApoB and Lp(a), up with your doctor directly. This is genuinely useful, evidence-based information that many patients simply aren't aware exists, and it may meaningfully change how your own cardiovascular risk is understood and managed. If you found this helpful, my next video breaks down exactly what a coronary calcium score shows, how the scoring system works, and what different results actually mean for your treatment plan. Make sure you're subscribed so you don't miss it. Take care of yourself. I'll see you in the next one.